I'm going to talk to you a little bit today about machine learning for health. And as you have heard, I do machine learning. I focus on artificial intelligence and making these models. And you might be thinking, why would you do machine learning for health? How does that work? Isn't machine learning for self-driving cars? Why would we want that as part of health? This is the far future that you're talking about. But actually, machine learning and algorithms are a part of healthcare right now. Whether we're talking about the statistical models that doctors currently use as risk scores in the intensive care unit, or we're talking about more advanced high-capacity models that are being trained to understand what sort of risks are relevant for patients and what sort of treatments might be needed. Machine learning and algorithms are a part of healthcare. Now, you may be wondering, well, how are you doing this? Why do we have machine learning in health, and how does it happen? Generally, how this works is we get clinical data from practice and from knowledge. By practice, I mean doctors. They practice. So if you could look at clinical records from a hospital, from a clinic, and see what sort of treatments are given, how patients are interacting with a healthcare team, you could learn from that practice, right? But then there's also knowledge. Maybe we don't just want to learn based on how doctors are practicing. We may also want to look at the knowledge that's been generated. Randomized controlled trials, RCTs, papers that are written, textbooks, right? We could learn from both of those sources. Once we have that data, we can train these simple statistical models or more advanced high-capacity models, and then we can predict things. Important clinical events, forecasting treatments that a patient might need. These are really important for healthcare and progress. So that's what could happen in the future. That's what we're working on. This is the goal of my group. What's happening right now? Because the data that we're getting to feed these models, to learn these rules, to train these algorithms, that's data that we're getting right now. And so the question that you should be asking, if we're learning from current practice and knowledge, is how much do you trust your doctors? Because we're learning from clinical practice. We're learning from doctors who are burnt out because we're asking them to do a huge set of tasks, not just provide clinical care. And burnt out doctors feel that they do not have the time to be empathetic to their patients. And that's the kind of practice that we're learning from. And doctors who are burnt out and feel that they don't have time to be empathetic are also, they're just human. Humans, even humans with ethics training and the best of intentions, are biased. And so it's been well documented that the biases of society are reflected in the healthcare that we provide. So this is what we get from current practice right now, no technology, right? What about knowledge? One of the big sources of knowledge is a randomized controlled trial, where you give one set of people a treatment and see how well it works in that population. However, randomized controlled trials are very rare because they're expensive. So only 10 to 20% of the treatments that are given today are based on randomized controlled trials. When we do have them, they are biased. Only 6% of asthmatics treated today would have been eligible for the RCTs used to design their treatments. Not only is the knowledge that we have rare and biased, sometimes it's just wrong. So more than 10% of the 3,000 plus top journal papers from JAMA, the New England Journal, the Lancet, were what we call a medical reversal. A paper comes out that says that thing you've been doing, common clinical practice, the thing we think is correct, that's wrong. We need to do something else. And so neither practice nor knowledge are perfect right now without any machine learning, without any technology. And this is understandable because right now, think about what happens if you're a clinician and a patient comes into your practice. Sumana's having trouble breathing. How are you supposed to decide what kind of care she needs? You're going to think about prior cases that you've treated and then try to assign an appropriate treatment. But the issue is that humans are actually reasonably unique. And so if I'm trying to assign a treatment for Sumana based on patients who are like her, I can go check the medical record. But prior work has shown that even if you take 250 million patient records from 4 countries and combine them, a large proportion of patients with common conditions have unique treatment pathways, meaning nobody else had a similar treatment history. And for common conditions like diabetes, depression, and hypertension, you would not assume this would be true. But 10% of diabetics, 11% of those with depression, and almost a quarter of those with hypertension have unique treatment pathways. What that means is Sumana comes into your clinic and says, can you give me a treatment based on patients who are like me? And you would say, no, there is nobody like you in 250 million patient records. So obviously, we can't use the practice and the knowledge that we have now perfectly. And so my goal is to use the complex data that exists about a person to train high-capacity models and try to provide better indications for doctors to provide care to their patients. And so if that's what's happening now without technology, maybe we can use technology to improve practice and knowledge. So let's go back to Sumana. She's having trouble breathing. She goes into the intensive care unit. What's the first thing we might want to do? We want to treat her. There's many different interventions that we could use. And so the first thing we might want to do is plan our practice, right? And so what we've done is we've taken the data from over 30,000 patients in the hospital and tried to learn what is the optimal practice. How do we predict the interventions that are needed for Sumana, given all of this data, so that we can plan her care? And that's important because when you use these deep neural networks to understand a patient's history, you can combine their notes, their labs, their vitals, all of their demographic information, and every 6 hours have a new updated risk for what sort of interventions might be necessary. And now that we've planned care, right, try to improve our practice, another thing you might think is, if Sumana is still having trouble breathing, I need to send her down to radiology. I think she might have a collapsed lung, a pneumothorax. But when you send a patient down to radiology, what's happening is maybe it's late at night. This radiologist has looked at hundreds of images. They now have to try to generate this knowledge, make this note. But they're tired, and they've seen so many of these kinds of images, and it's a very tedious task. So another thing that we've worked on is going from hundreds of thousands of X-ray images to the radiology reports that would have been written about those images. And that's important because if we can use high-capacity models like convolutional and recurrent neural networks to make clinical text that is both accurate and human-readable, we're allowing a doctor to make better decisions about care while removing a tedious part of their day. Another thing to think about after we've improved this practice and we've provided more knowledge is exactly how we're doing that. So Sumana is a minority. How do I ensure that the treatment that she's receiving is fair? And remember our prior slide, humans are biased, right? And we're learning from human-generated data. So as an example, we took some text and asked a neural network to complete the blank. And here, the only thing we changed was the patient's race. So 71-year-old Caucasian patient is in blank condition, was DNR, do not resuscitate, in the nursing home. If I change the race in this sentence, it shouldn't change what gets filled in the blank, right? But it does. And it does because this model was trained on real data generated by people with real biases. And this is important to establish because when we train high-capacity models, we need to be able to audit them and demonstrate, for example, how well they do on patients of different protected classes, different ethnicities, different genders. And importantly, it could be that this model performs better than most doctors in your clinic. right? The average performance, even though it varies across these protected attributes, could be better. But whether we're comfortable deploying an algorithm like this that could improve care, but at different levels for different people, this is an ethical question. This is a societal question. This is not something that the machine learning algorithm can answer for you. We have to make that call. So my group broadly focuses on creating actionable insights in human health. We focus on creating models that are healthy. So can we train models that work well in a medical setting? What kind of healthcare is healthy? Once you've trained a model that works well, can you then use it to interrogate healthcare and establish what works best for people? And finally, what kind of behaviors are healthy? Because ideally, we don't want to just recommend optimal treatments, improving practice and knowledge. We'd like to keep you out of the hospital entirely. Thank you.